liver is really your mirror of your metabolic health. If you are lean or obese but have fat in the liver, it's just telling you your insulin resistance and unhealthy metabolically. It could be your genes. We can blame our parents, as we like to do, or it could be poor dietary habits or lack of physical activity. Steatosis is a great marker of future bad things to happen. It's a very exciting time, and I'm very upbeat. I think if there's a patient listening who has NASH or a doctor who is treating people with NASH, these are wonderful times. We have currently 2 diabetes medications that can help their patients, pioglitazone and GLP-1s. A number of studies have been out this year showing weight loss by any means helps. There have been a number of nice bariatric surgery studies, just one in JAMA showing that you reduce liver and cardiovascular outcomes with bariatric surgery.
Hi, this is Roger Green, host of the SurfingNASH's podcast. Today, we are offering a conversation from episode 63, the second of our 3-part year-end series. The episodes offer shortened conversations with our opinion leaders. This piece shares our entire conversation with Ken Cusi on how specialties besides hepatology have come together in the face of the NASH pandemic, culminating in the recent Clinical Care Pathways article and an earlier piece on aligning to fight the pandemic. This conversation represents a candid, detailed discussion with a major opinion leader on a subject he discusses passionately. So sit back, listen, enjoy, learn, and when you're done, join the discussion on our LinkedIn and Facebook discussion groups. Okay, so we're back now with our good friend Ken Cusi, who's been with us for a couple episodes in the past year, and I think a couple of conferences as well. Ken, how are you today?
How are you, Roger? Thank you for having me.
Thanks for joining. I'm doing fantastic. This is, as Louise has reminded me, our 3rd out of 5 today. Louise, how are you?
I'm doing very well. I'm looking forward to what Ken's got to tell us.
Yeah, I as well. So, Ken, as I think we've discussed, this series of interviews is about major things that have happened in fatty liver in 2021 and what they portend for the future. And certainly one of those has been the multi-specialty effort in the U.S. to coalesce around the need to treat and a process for treating the disease. And you've been certainly up to your keyboard in that. And I think well beyond your keyboard, probably to your shoulders or neck as well. So let's start by talking a little bit about the progress that was made in 2021 and what kind of feedback you're getting from the broader communities right now about the work.
Well, Roger, that's a great question. It's a broad question, and I think we only have a little bit of time here. But again, there has been a much greater awareness this year beyond the liver field and hepatology trends that is based on new data this year from the United States and abroad that shows that fatty liver disease and the risk of cirrhosis from NASH is a real thing. I still have peer endocrinologists say, hey, I never had anyone with a cites come to my clinic. And the reality is that is slowly changing. The studies that our group and others did using NHANES data, the big national survey that assesses many health outcomes, says that about 2 out of 3 people with type 2 diabetes and probably a close number of those with obesity without diabetes have NAFLD, and maybe 1 in 5 or 1 in 6 have significant fibrosis. So these numbers are beginning to not only get the attention of primary care doctors, but everybody who manages chronic diseases like obesity and diabetes. I think that was several decades ago with cholesterol awareness. I mean, it doesn't happen overnight. It's something that builds momentum, and momentum is building because different societies like in the endocrine field, in primary care, in obesity, like the Obesity Society, at least in the United States, are coming together, and we discussed in other podcasts the clinical care pathway. Not only that, but also at an international level, the efforts that we did in this simultaneous publication in Diabetes Care, which is the official journal of the ADA, in Gastroenterology, which is the official journal of the American Gastroenterological Association, also is published in Obesity, the official journal of the Obesity Society. These are big journals that are saying, hey, we have a problem. And there were international leaders there. The other effort is the effort done across the ocean, led by Jeff Lazarus in Wilton Park. And he has gathered really a fully international community of leaders and all kinds of not only liver experts, diabetes experts, primary care. And they have published a couple of nice reviews this year, and one in Nature Reviews, highlighting the gaps and bringing awareness. So I'm very excited. And there are some guidelines coming in 2022, and there have been new drugs that have been successful. We've had also some failures. So as life, a mixture of good and bad.
So Ken, I should mention that when Jeff was on talking about the public health agenda paper, he cited the clinical care pathways work that you've done in the U.S. as one of the really exciting and remarkable events of 2021. So,
oh, great. I didn't know that. So I'm so excited now. Thank you.
Ken and I were at the last Wilton Park. Actually, I watched Ken present at the last Wilton Park event.
Exactly.
Where he said he had 5 minutes to present, ran in, presented for 5 minutes, then went back to whatever else he was doing. He's a busy guy. So that's the foundation, right? Part of the foundation is the work that Jeff is doing with Easel and the Wilton Park folks. Part of the foundation is the work you're talking about here in the States. So what do you see in 22?
2022 is going to be a great year, I think. Number one, I can tell you, for example, on the liver, my friends, the hepatologists, are updating the AASLD guidelines. The guidelines are American Association for the Study of Liver Diseases. So that's going to be out in, I suspect, early 2022. And they will incorporate some progress made in the diagnosis and treatment of NASH from the endocrine end. I can tell you that the American Association of Clinical Endocrinologists. There are two big endocrine groups. That's one, and the other is the Endocrine Society. Well, AACE is going to release guidelines in January. The first guidelines for endocrinologists complementing the work of AASLD, and we have a couple of members of the AASLD committee, Dr. Rinil and Dr. Yunusi, who were very instrumental in giving their worldwide recognition as experts in the field. So that's coming out. I'm talking with the American Diabetes Association to update the ADA guidelines. The ADA guidelines was very bold in 2019 to recognize the need to screen, although the current recommendations are to seek for fibrosis only if you have fat in the liver or elevated liver enzymes. A minority of people have elevated liver enzymes, so that's not sufficient. So the work that we are doing currently is more along the line that everybody get a FIB4, which is the calculation from age, liver enzymes, and platelets to try to identify, to rule out people with cirrhosis at least. So I think the ADA is going to be moving forward. And I'm very excited as also the work of Jeff and colleagues is moving forward with advancing the awareness among this. And I also know that phase 3 studies are starting with drugs that have proven to be effective in 2021, like Semaglutide and lanifibranor. So there are good things that are happening. And again, there's also a broad spectrum of other agents that are moving forward, although we had some setbacks, as you know, from the AASLD meeting.
This is a kind of an inside ballpark question. You mentioned Sema and Lani and not resmetirom. Is that just because you weren't thinking of resmetirom, or is there a way in which you think of it as being different from the other two?
Well, resmetirom has promising results. It may make it more liver specific, while the field of outside the liver field are excited about the other two compounds is because they have so significant cardiometabolic effects on diabetes, on the probably cardiovascular risk, and major effects possibly on some of the lipid fractions, which the resmetirom has some. And again, the effect on steatohepatitis was larger with both compounds compared to the Madrigal compound. This is going to be a multi-pharmacy kind of, one agent alone is not going to get the job done for most patients.
Okay, that sounds right. So good news on drugs, good news on organization moving forward. Louise, what questions do you have before I keep going?
I think the AGA pathway has been phenomenal in the context that it's easy to follow, it's very directive, and it's actually hard to get it wrong. And if in doubt, just follow it. That, to me, makes it very applicable to primary care. All of the strength of Ken's work and Jeff's work and Wilton Park and all of the establishments is it's collaborative. It is throughout the disciplines, because we do need to work together. There was a letter to the government here last week by a lot of major food industry worth over £3.8 trillion, for example, asking for food labelling to improve to help society. So we're also now seeing, and certainly Jeff's work and the last Lancet recently, it was about collaboration, and we cannot do it just the medical world. It has to be a societal thing. Ken's work with that side, bringing it together, making it easy from a primary care perspective. I can implement it as a nurse specialist, as an advanced practitioner. I can look at how we can support primary care implementation of secondary care, diet groups, weight management, weight loss management, how we can work collaboratively. Those are the strengths of what Ken's described and what Jeff has described. That to me is the exciting part of 2021. Then we add the medications. Then we add, let's get people's awareness up about poor liver health, because you should never really get liver disease if we target poor liver health earlier, or necessarily diabetes. They are aligning, and it is through this great work. So I'm just excited to hear what Ken's got next up his sleeve. Yes, we've got these new guidelines coming up. Where do you see 2 or 3 years from now? Because the movement is now gathering traction.
Well, that's a great question, Louise. I remember the first time I said we have to screen people with diabetes in the same way we do for retinopathy or nephropathy was a review in 2008 for an ADA journal. But not much happened for the next 10 years. And I think we've made more progress in the past 12 months than in the past 10 or 12 years before. And that is because things kind of gather a momentum. And I think the momentum is now. And what I think is going to happen now is that there's going to be a convergence of awareness. People are going to begin using the FIB-4, particularly if the American Diabetes Association gets on board. And this is going to coincide. Unfortunately, the FDA-approved drugs are still going to be 2023 and beyond, I think, given the phase 3 trials as they go. But, I mean, another 2 good things happen to gain momentum. For example, in the United States, diagnostic testing is improving. The ELF test was approved in September or so, which in Europe and the rest of the world had been available for some time. And that's a test that has good validation, and it's going to begin its marketing soon. I also know that the ProC3 test from Nordic is partnering with a big company to make it automated and available commercially. So that's probably going to be next year. So they're blood tests that can complement the imaging by elastography. So diagnosis is going to improve. And again, what I think is very important is that as the ADA and other diabetes societies get on board, diabetes and obesity is the tip of the iceberg, right? The one that concentrates it. But then the next will be moving down to people with obesity. But the strategy, I think, is to establish a universal screening for the highest risk and then move our way down to more broader and more difficult to grasp groups. We are doing a study now screening 1,050 people, about half with diabetes and half without diabetes, because we don't know what the prevalence in people without diabetes really is in our clinic. So we hope to finish that by the mid of next year and then come up with some numbers to guide the guidelines moving forward, at least.
Are you screening them by following your guidelines for FibroScan? Is that the way you're screening these 1,000 people?
Well, it's a little bit of a research approach in which we're doing a FibroScan to everybody, which wouldn't be what we would do in routine practice. But we're also doing FIB-4 and a bunch of commercial markers. So when we put all the pieces together, we're going to see how well the FIB-4 plus minus FibroScan can work, and then how the other tests complemented. When we put all the pieces together, we will have some sort of a pilot study to later do this at a larger scope. For example, I have worked at the VA for 25 years, and they also putting out some guidelines and beginning to implement FIB-4. It's a very high-risk population because they're older, have a lot of diabetes, a lot of obesity, and a lot of comorbidities. What I see is that at all levels, this is really becoming something of value, and also by the scope of the broad number of different meetings and where they asked me to talk about this, which is not what happened just recently.
Can I just ask, when you do those patients, are you blind doing the tests in the context of, for example, my practice, my lifestyle side, where people just walk in, I can tell who I think needs a FIB-4 or who I think needs thing. Are you going to say, right, we've done 1,000 plus FibroScans, how many of these would have had a FIB-4 of X or a FIB-4 of Y, and see how, because I think if everybody had a FibroScan first, you'd pick up poor liver health, and that directs you, because it's costed where it is at the moment to make it so expensive in the way of the pathway that actually it's still a serial test, whereas it tells us fat, tells us stiffness, it tells us who has problems that we should be looking for, rather than waiting on a blood test telling us who we should then be fibroscanning to find out they've got cirrhosis or they've got advanced. So is there an option?
That's a great question. So the big big debate is how do we screen a large number of people without bankrupting the system, right? Or clogging the system up with FibroScans or other tests like commercial tests, and what is the yield? So the resistance, for example, in the past guidelines, at 2018 AASLD guidelines, which why I was a member, there was a big divide between those who said, no, let's just do the FIB4 to everybody with diabetes as the highest risk group. With type 2 diabetes, we're talking, right? So then others said, well, we don't have the evidence or the outcome data. But my point was, if we don't start, we'll never have the outcomes data. It's like colonoscopies. When they start doing colonoscopies, we didn't know if it was really cost effective or not, right? And expensive. So answering your question, at this stage, we're just doing it to anybody who has not had a FibroScan before, or anybody who has been told beforehand to have a fatty liver. So it's blinded, random, and as unbiased as possible to later say, well, which would be the most cost-effective approach overall. Because you should remember that although we are pushing the FIB4, we do it because it's free, because everybody will get a CBC in a year or a liver enzymes once a year, but it's not a great diagnostic test. It's a test that helps rule out advanced disease, but not very good to pick up cases that are moderate or mild. So I think the greatest value is just beginning to put that little habit in primary care doctors until better tests become available.
Yeah, we know that liver fat is not benign, so even without a stiff liver, if we can alter liver fat and keep them on a healthier perspective, that's a cost-effective, for me, getting somebody off the timeline for NASH, for NAFLD, cardiovascular disease, type 2 diabetes. So it's all-encompassing rather than just, we like to silo. We're the NASH tsunami, yes, we're looking at NAFLD here specifically, but if we only take one, we miss the other advantages, I suppose.
Yeah. As I like to say, the fat in the liver is really, your liver is really your mirror of your metabolic health. So it's your mirror. If you are lean or obese but have fat in the liver, it's just telling you you're insulin resistance and unhealthy metabolically. It could be your genes. We can blame our parents, as we like to do, or it could be poor dietary habits or lack of physical activity. Steatosis is a great marker of future bad things to happen. And again, as you know, Louise, there have been many studies looking at cardiovascular outcomes, and they've been a mixed bag because the quality in most is not great. They've used ultrasound, which is not the most sensitive test. They've taken one time point and again another time point years after. They've used many surrogate markers of cardiovascular disease like intima-meal thickness, which carotid intima-meal thickness, which is not great. And when you correct for traditional risk factors like hypertension, dyslipidemia, and diabetes, these differences tend to shrink. But we all agree that having steatosis is something that's going to tell that bad things will happen from you from a cardiovascular endpoint if you live long enough.
That all is great. And then my question becomes how we take all this knowledge and important insight and shoehorn it into schedules of people who have no time to bring it in anyway. And Stephen most eloquently, but other folks have talked on this podcast about how overburdened primary care is and how overburdened really everybody is, but particularly primary care. So given the practicalities of how health systems work, let's stay in the U.S. for a second. How do we take all this great momentum and knowledge and translate it into getting patients treated earlier and better? Can you have any vision for how that actually will work?
Primary care doctors and endocrinologists get bashed by the liver doctors saying, oh, guys, you don't do anything. I throw it back to them saying, well, you guys don't even measure an A1C in your patients with NAFLD many times. But also, in a follow-up visit in the United States, we are asked by our division chiefs and higher-ups to see our people with obesity, type 2 diabetes, cardiovascular disease, retinopathy, nephropathy, hypertension, dyslipidemia, sleep apnea, low testosterone, low thyroid in 20 minutes. And those 20 minutes, I need to know how he's doing, gather the history, do a physical exam, reorder all his medicines, order new labs, and write my note. And tell them, by the way, we just found out that you have cirrhosis. So it is a challenge. So I've been giving a lot of thought of this. I think what we have to do is that's why the clinical care pathway tried to make it simple. With a FIB4, which is a fairly imperfect test, but at least it will catch people with F3, F4, with advanced liver disease. And what we are doing in our institution, we are now putting the FIB4 into the electronic medical records of all doctors. And if it's high, it will pop up up their window saying your FIB4 is high, consider ordering, and we put the clinical care pathway for them to just order the FibroScan and take it from there. And in settings that don't have elastography, to do an ELF test or send to the liver doctor. So I think those automatic reminders will be taking advantage of the electronic medical records. The other downside is that endocrinologists probably won't get paid a penny more for diagnosing cirrhosis or spending 10 minutes more with their patients. So there's an economic side to that. And not to mention, COVID has really exhausted the emotional and physical energy of all of us in the healthcare profession. So we're really tired, and now we have another wave of Omicron coming. So this is not the best time to ask for more screening for a new disease. Automating, making it simple. We don't have a hemoglobin A1C for NASH, but I think the FIB4 will at least get those with more advanced disease to see their liver doctors. That's a simple test, simple movement that should be embraced broadly. In most settings in the United States have electronic medical records, and it wouldn't be that complicated to do. Of course, I don't have a great answer. I know what you're looking for, but automated things that will take just seconds to order a second test are the way to go.
Actually, what I was looking for is an acknowledgement of the idea that it's going to be easier to figure out what people are supposed to do than figure out how to get them to do it. And I think you kind of answered that one by saying, yeah, that's right. We're going to have to work harder on that one.
There's no easy answer. How long did it take for people to order routinely lipid testing or to send them to the eye doc? When I'm this old that we started ordering albumin in the urine, and still I was reading an article the other day that 30 years later, still only 2/3 of people with diabetes get it all the time, every year, at least once. If you achieved your dreams in a single lifetime, you're not dreaming big enough. This is going to take a long time, but we got to get started.
But I will tell you, we did get started. Following your session, I had the pleasure to talk to 55 primary care physicians and registrars, and we talked about non-invasive technologies with some of the team at King's, and we just added FIB4 to their desktop so that they can do it. They can have access to it. They're aware of it.
Wow.
And their knowledge before and their knowledge after did it. And we used EASL and we used your guidelines as examples. One of the papers from AASLD with primary care using FIB4. So they were very keen. They were very interested, and they were very surprised to see the potential level of liver disease within their communities that were easily locatable using FIB4. So I think we are trying to make those changes. That's why I said earlier, your pathway is so clear and achievable. Comorbidity clinics for me, a multidisciplinary side, achieves you getting the best time with your patients if we can do that.
Yeah, so Louise, just very brief, two thoughts come to my mind. Number one, I'm a little bit uncomfortable when you say your pathway. It was an effort of like 30 top experts in the world. Dr. Canwell and Dr. Shubrick were the other two that did a lot of the effort, but it was a collective effort. And I know you're very kind with me. That's why. Thank you. But the second thing, the same thing happens here. The primary care doctors are excited. They want to do it. They want to help with this. For example, I teach a lot of young doctors, like our endocrine fellows. It's actually in the last 2 years been the first time that they calculate the FIB4 when they present the patient. They tell me what the FIB4 is, which never heard before in my 30 years of career. These little victories are things that give us the energy to keep working hard and changing the current paradigm.
But this was going to be my observation, Ken. I hope this makes you feel good. It's not designed to do that, but it might work. The way that human dynamics work is that you chip at something in little pieces, and then, like, for example, the Berlin Wall, that all comes down in the night. So the thing that happened with lipids that changed the playing field, at least in my mind, were two things. One being not the arrival of statins, but that the arrival of statins motivated the reference labs in the U.S. to change how they defined elevated cholesterol from 2 standard deviations over to the mean to 300 milligrams, which is like 30% of the population. And then the second thing was that atorvastatin came out with rather mind-boggling outcomes data. Now, the outcomes data here, I think, is a ways off, but we should be able to do some work on the reference labs to identify some of the scores that people get back, even to their basic physicals, to say, if you see this result, look for this and think about doing this test. So I guess my question to you and Louise, both of whom think a lot about this kind of stuff from different perspectives, as a guy who's last natural science course was high school biology, what point or points of leverage can you see where you can flip one or how we interpret one or two numbers on a standard panel or an expanded panel, and in the process get people to understand the scale of the issue?
Louise, ladies first, I'll let you.
I think think I'd go back to Stephen's part of AST-ALT ratio. It's usually there. Most people do that. It's the one that people can recognize straight off if they look for it. Stephen tends to keep it simple. I love his KISS, keep it simple, stupid scenario. Donna says a tape measure. I think I can think of scales. You could think of all sorts of things. If I was looking at a blood panel, it would probably be ALT-AST ratio. But when we do assessments around the country and we look at data, there's a lot of places do not do simple liver enzymes. The liver's not designed to let you see in a blood panel. It regenerates. It's not supposed to tell you it's sick. So actually, if we don't do the best blood panel we could possibly do for the liver enzymes, then it's very difficult to take any markers. I think Manal commented earlier about platelet counts. They all have problems. I'd keep it simple and probably go ALT-AST ratio. If I just had to pick one straight off, that's the easiest one for them to look at.
Yeah, my turn here is, of course, I'm thinking if the labs could incorporate FIB4 within the Chem 20. The only challenge, they would have to have a platelet, which are not always ordered. But maybe if most primary care doctors, when they order the routine Chem 20, which has a routine, labs including liver enzymes in the United States, they order a CBC, a complete blood count. So in that setting, the big companies here, Quest, LabCorp, could automate a report including FIB4. That's one thing that could be done. The other could be to lower the upper limit of AST and ALT, which is currently 40, and bring it down to 30. And with that, they would begin catching people a lot earlier. And if that is done in combination with the EMRs calculating their FIB4, maybe that could be an easy alternative. The AST-ALT is another great idea. The only problem is that ALT goes up first, so you can have an ALT that keeps the ratio below 1. By the time AST is up, you're kind of late in the game. But it's better at least late before you show up with decompensated cirrhosis as nowadays. So nothing is going to be perfect, but I do think that Roger touches on an important point, that we have to have the commercial labs involved with this. I would have to say also commercial labs are very interested in commercial biomarkers and things, which could help, but that's a second or third step. This is going to take multiple approaches. And again, the other point that you mentioned, Roger, was statins made a big difference because resins and was a suboptimal, and others like niacin did not really move the needle of awareness about lipids until statins, made it with, I think 4S was the first big study with simvastatin that showed a huge reduction in cardiovascular events for secondary prevention, particularly in people with diabetes. So that was really like a nuclear bomb that said, wow, we got to do something. I remember that taking simvastatin for 4 or 5 years reduced 50% reinfarction in people with diabetes. The outcomes are going to take longer here, but the drugs that are in the market will have huge effect. As you know from the Sema and lanifibranor, the 2/3 of people roughly respond for steatohepatitis, a little bit less with resmetirom, but these are going to be positive results. And by the time they are out, people will be really ready to embrace them. The other big change that happened, Roger, and I'm going to stop talking in a second, but was that semaglutide, the obesity dose, was approved in the United States. And the other big thing that happened in the second half, there were 4 publications with a SURPASS program, the tirzepatide, which is the combination of GLP-1 plus a GIP agonist with weight losses in the range of the weight loss dose, the high dose of 2.4 of semaglutide. This is undergoing FDA review and will be approved in the first half of 2022. This is also going to push greater pressure for these drugs to be approved by insurance companies because of the cardiometabolic benefits, and they have also a NASH program that's a little bit behind. So all of this is going to really change the way we look at NASH and cardiometabolic disease in the future.
So my only comment was going to be, I wonder what role Splendor is going to play in this, because the idea that you can have that kind of impact, literally, right? A 4-fold decrease in malo, cutting MACE in half, and over a 10-year period affecting 7.5% of patients with each by having successful bariatric surgery and 20% weight loss, particularly given what you're seeing with tirzepatide looks a little lower, but there are some other double and triple agonists in development that are showing over 20 in early stage trials. We may get to a point where that's a realistic thing.
Just to put for the audience who may not be so aware of the literature like Louise or Roger, the current diabetes drug for dose for semaglutide, it's weekly, is 1 milligram. They are going to get the 2 milligram approved soon. It's under review. So that's going to lead to larger reductions in weight. The 2.4 milligram of semaglutide in individuals with obesity without diabetes shows reductions up to 16%, and in people with diabetes, 12%. So typically people with diabetes, for unclear reasons, lose less weight. The numbers with tirzepatide are in that range to 16% and 12% in people with diabetes. The only real thing that will limit their use is coverage. These drugs are expensive. That's something to keep in mind. That's why I say pioglitazone is the metformin of the field, because it's dirt cheap, costs less than $5, and the 15 milligram causes 1% weight gain. And if you combine it with sema, you don't gain weight, you keep losing weight. Insurance companies are not going to be able to deny these medications. For example, the Veterans Administration system, there was a lot of denial in the past to use semaglutide, and now it's fairly easy to get it approved because it's cost saving to the system in the end.
Well, when the economics work for you, they work, right? That's a good thing.
The interesting thing, Roger, is that the cost for the government of semaglutide is about 20% of what you can buy it in a pharmacy. You can imagine that. I hope the companies will pitch in with more affordable pricing, at least in the United States.
Okay. Do you want that to be your last comment, or is there anything you'd like to close with that's a little more visionary and upbeat? Your choice.
Well, I mean, it's a very exciting time, and I'm very upbeat. I think if there's a patient listening who has NASH, or a doctor who is treating people with NASH, these are wonderful times. We have currently 2 diabetes medications that can help their patients, pioglitazone and GLP-1s as a class. Semaglutide has the best evidence. We know now a number of studies have been out this year showing weight loss by any means helps. There's been a number of nice bariatric surgery studies, just one in JAMA showing that you reduce liver and cardiovascular outcomes with bariatric surgery. I think it's all good news. I mean, some of the drugs that we had higher hopes, like FGF19s, FGF21s, turn out not to work as well in the last meeting. But again, lots of awareness, lots of good things coming, big societies supporting changes in the way we talk to patients about liver disease. It's all good. We have a way to halt the progression of NASH in our patients. So great times are going to come, no matter how difficult COVID is making our life. The liver field and our patients should be very excited about what's to come.
That's a great close. One small editorial comment. Our last speaker noted that one FGF21 going down doesn't mean that they're all going to be a problem.
Absolutely. There are like 7 there's one, and they all have they target the FGF21 receptor in different ways. So I just didn't want to get too specific down. But again, there are many ongoing trials with FGF21s at this point.
That might actually be even another piece of optimism over time. But Ken, thank you. It wouldn't be too much to say that the best things that happened for patients this year in fatty liver were the result of people like you, and to a significant degree you, banging on this thing when it didn't give it all. So starting to see cracks in the wall is really a good sign. As I say, the Berlin Wall went down in the night. It might even be that you're around when all this happens. It might take a lot less time than you think. And frankly, for the sake of you and all of us, I hope it does.
I'm excited. And again, it's people like you, Roger, doing this podcast, Louise, with all the great work she does in the UK. One step at a time. Once the train leaves the station, it's unstoppable. Let's keep doing our little contribution day after day.
We will be the little engine that could. I think that's great. Thank you, Ken.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. And join me again tomorrow, December 30th, for our conversation with Jorn Schattenberg.